Hi guys, welcome back everyone. So I'm going to take 10-15 minutes of your time to give you a briefing about something that has got me excited. So tomorrow on the PW Meded YouTube channel, we are launching a series which we are calling it as Pocket Clinics, where we will help you to take symptoms to diagnosis. But first of all, why am I excited and why PW felt the need to launch something called as Pocket Clinics? So when I was a medical student, when I got into a medical school, I had a perception that okay, I will finish my MBBS, and once I finish my MBBS, I will be a good doctor. If I'm passionate, maybe I'll go into post graduation, but if not, I'll still be a good doctor with MBBS. Because when I was sick as a child, the doctors whom my parents used to take me to were all MBBS, what we today call as plain MBBS. None of them were pediatricians or surgeons or physicians, but they were confidently handling most of the common cases. But then when I finished my final prof, cleared it successfully and got into internship, I had my first reality check. Went to the wards, absolutely clueless what to expect. And when I started seeing patients, nothing seemed to make sense. Like, why is this a case of tuberculosis? Oh, because investigation said so. But what made my physicians or the professors think that this is a case of tuberculosis? Why is this a case of malaria? What made them think of this case as a malaria? I know report is positive, but why they started thinking of this as malaria? None of those made sense to me. So I just became a clerk, just like what most of the students do today. I wrote discharge summaries, I filled case sheets, I wrote prescriptions dictated by my professors. I was not confident to handle common cases. And almost 15 to 20 years down the line, the story remains same. Today's medical graduates who complete final prof and get into internship are not capable of handling common cases. See, for a country like India, tuberculosis, dengue, malaria, enteric fever, hypertension, diabetes, these are pretty basic cases, right? Every doctor should know to handle them. This should not be specialist terrain, but unfortunately, most of the people getting into the internship are not confident enough to take a case of hypertension and initiate the initial management. If it is a resistant hypertension, fair enough, you can say that it's not my cup of tea. Some specialist or at least a physician should step in. But how many of you are actually confident enough that if I recognize a case of hypertension, I will be able to initiate the initial treatment? Or if I get a patient with fever, I'll be able to at least come down with a narrow differential diagnosis that this could be viral or a enteric or a tuberculosis or a malaria. Well, unfortunately, the answer is not many of us, right? But then don't you think literally 4.5 years spent in medical school and those 19 subjects studied are not making you confident enough to handle common cases? So if that's the situation, something is wrong with the medical education for sure. It calls for a rethinking about the medical education. And that's what we did at the PW. We were like brainstorming why our fresh MBBS graduates are not confident enough to handle even common cases. See, in the medical colleges, the discussion is like every new generation of medical students, the quality of doctors is just deteriorating. This is what we have been hearing from my MBBS days. So my professors used to tell, you guys are substandard. When we were medical students, we used to be confident enough to handle all this, but you guys are substandard, you're dependent on your seniors and professors. And then when I entered the medical school, I hear my peers or colleagues talking the same thing. When we were medical students, we could handle so much, but the new generation is deteriorated. And I'm very sure those students who studied under me, some of them are now medical college assistant professors or associate professors, and they will also be making the same statement. But then just passing the blame, saying that every new generation is downgraded, is not the solution, right? We need to actually upgrade the standard of doctors coming out from medical schools. So when we brainstormed and tried to figure out why our MBBS graduates who score distinctions are also not very confident in facing the patients, analyzing the symptoms and making the diagnosis. And one common pattern that we recognize is that in medical school, we learn the diseases in a fragmented way. To give you an example, You have studied about asthma, you have studied about COPD, you have studied about interstitial lung diseases, you have studied about pneumoconiosis, you have studied about sarcoidosis, you have studied about tuberculosis, pleural effusion, pneumothorax. Okay. Now, in all these diseases, you come across two common symptoms. One of them is cough. The second one is shortness of breath. So next time when in your internship, you face a patient in the emergency room with cough and shortness of breath, all these are possible differential diagnoses. If I ask my intern to tell me about sarcoidosis, he will talk to me about sarcoidosis for 10 minutes because he had studied about it. If I ask him to tell me about COPD, he will talk 10 minutes on it. If I ask him about asthma, he will talk 15 minutes on it. And if I find out some finding in the patient and ask him what is this finding, he may be able to recognize it. He will tell, sir, this is Hoover's sign, suggestive of severe COPD. Sir, this is Campbell's sign, the tracheal descent in inspiration, suggestive of severe emphysema. He will give those answers. But when I leave it to him to take the history, examine, do necessary investigations and come out with a diagnosis, they are not capable. Because we have studied the diseases in a fragmented way and we have not studied a symptom-based approach. Instead of studying the diseases in a fragmented way, what if the medical education focused on taking a complaint and then navigating through the history to come out with a narrowed down differential diagnosis? See, all the conditions are listed, patients present with cough. But what if someone had taught you that if someone is complaining of cough, how you reach the diagnosis from cough as a symptom to diagnosis? How you navigate, how you rule out that this is not likely to be asthma or not likely to be COPD, and how you rule in or favor one diagnosis over other. Like, why is it more likely to be tuberculosis or why is it more likely to be pneumoconiosis? So navigating through the possible differentials by looking at the symptoms, duration, presentation, associated additional symptoms, history parameters, and then the clues that you derive from examination, so that you come down with a very narrowed down differential diagnosis. That's where the beauty of being a doctor lies. And unfortunately, this has been seriously missing in medical education. Because see, even for practical exams, we know that, okay, what are the common cases they will keep? Okay, they will keep COPD from respiratory medicine, or they will keep lung fibrosis or collapse. And if it is serious, they will keep one valvular heart disease. In all probability, that will be MS or AS, or sometimes rarely MR. If it is a neuro case, it will be a case of stroke, most likely hemiplegia, or a case of spinal cord injury with paraplegia or quadriplegia. Or if it is a short case, maybe a diabetic peripheral neuropathy. So everything is predictable. So we go prepared to face the questions rather than face the reality of seeing a patient. Well, so you can easily pass those exams, but when it comes to facing the patients and then passing the test of real life, well, that's where we lack. So let's not make this MBBS a plain MBBS, just a time pass or a stepping stone to get into PG. Yes, I definitely want all of you to study the theory, the fragmented way the curriculum is designed. I also want you to study the approach to MCQs, and that, of course, all the teachers on PW method, we are constantly striving to help you prepare for your FROP exams, prepare for your practical exams, and also prepare for your MCQ based exams, be it INICET, NEET PG or FMGE. But at the same time, being doctors, being medical educators who derive benefits from the students, it's also our job to give the right direction so that the future generation of doctors are confident enough to handle cases. So that's why PW decided to launch pocket clinics where each faculty will bring in some common symptoms from his specialty and then help you learn how you navigate those symptoms to reach the diagnosis. If not a sure diagnosis at the level of history and examination, at least differential diagnosis, so that going forward in your internship, you are not going to be considered as a kitabi kida, right? A bookworm. Rather, you are there in internship to make the most use of internship. And I keep telling this again and again. Going forward, the examinations are going to be focused on assessing your approach to symptoms, which we have also already started seeing as a trend in INICT and to some extent in NEET PG, and in the recent FMGE also we have noted that trend. And trust me, more than 1/3 of the MCQs coming from the medical curriculum will be testing your ability to navigate through symptoms to diagnosis, rather than coming out with the diagnosis based on the buzzwords. Yes, buzzword based questions will continue. They will tell, oh, worst headache ever, it is subarachnoid hemorrhage. But there will also be questions of real subarachnoid hemorrhage patient's story embedded in the question, where they may not be mentioning worst headache ever. There may be additional clues from the history, examination, investigation, so that you come out with the diagnosis of subarachnoid hemorrhage. So for half a decade or so, yes, exams, that so-called clinical vignettes, primarily focused on buzzwords. If you hear that buzzword, it is this question. If there is a question with a headache and they are describing it as a band-like sensation, then it is tension type of headache. Headache with photophobia, phonophobia, nausea, vomiting, it is migraine. So those buzzwords will continue to be there. But apart from that, truly clinical questions have started appearing, and the number is going to increase. So you can't take the internship lightly. So internship is no longer just 1 year of presence in wards, but preparing for MCQ exam. No, you have to seriously make use of the internship time to learn from the patients, so that if questions are asked from your patient-based experience, you can deal with that also in the MCQ-based exam. And at the same time, when your relatives send some reports or tell the story or history of some relative going through some problem, you will not be out of place. You will know that, oh, okay, from the history it looks like COPD, so why don't you go to the physician and get a spirometry done, and you will have the diagnosis done. So that confident I want to see among all medical students today. So that's why we are starting this pocket clinics. It is beginning from tomorrow, and every PW Med faculty has put a lot of effort to make sure that these are concise and extremely high yield approach to symptoms. And all the faculty are going to select the most relevant symptoms from their specialty, so that the time spent on these videos is not going to go waste. Okay, now you will say, sir, you will take lessons at that point of time. We understand, but then later we will be left scrambling to look for the notes. So PW has now made a more sorted way of delivering notes to you after the lectures. So we will be following a Google form based approach. So after each video, in the pinned comment, there will be a link to a Google form where you share your details, and the notes will be directly delivered to you, so that you don't have to get into the Telegram and start searching for, okay, where is this particular lecture's notes. So guys, welcome to the era of becoming good doctors and not just plain MBBS doctors. Let's begin it from tomorrow itself. All the best, guys, and I'll see you in the pocket clinics. And trust me, I'll certainly help you to deal with at least common symptoms from medicine.